Introduction to Dermatology. Dermatology is the branch of medicine focused on the diagnosis, treatment, and prevention of diseases of the skin, hair, nails, and mucous membranes. It encompasses a vast array of conditions, from common rashes to complex autoimmune disorders and skin cancers. Understanding the foundational principles of dermatology is crucial for effective patient care and public health initiatives. This field integrates knowledge from various medical disciplines, including immunology, pathology, and microbiology, to provide holistic care. The role of a dermatologist extends beyond treating visible symptoms, often involving systemic health assessments. Continuous learning and adaptation to new research are vital in this rapidly evolving specialty. This course will provide a solid foundation for dealing with skin diseases. The skin, as the body's largest organ, serves as a primary protective barrier against environmental insults, pathogens, and UV radiation. It also plays critical roles in thermoregulation, sensation, and vitamin D synthesis. Disruptions to these functions can manifest as a wide range of dermatological conditions, impacting both physical health and quality of life. Recognizing the intricate functions of the skin is fundamental to comprehending the pathophysiology of skin diseases. Effective management often requires a deep understanding of how various internal and external factors interact with this complex organ. Therefore, a comprehensive approach to skin health is essential for all healthcare professionals. Skin anatomy and physiology. The skin is composed of three primary layers: the epidermis, dermis, and hypodermis, each with distinct structures and functions. The epidermis, the outermost layer, provides waterproofing and protection against pathogens and UV radiation. It consists mainly of keratinocytes, which produce keratin, a tough protective protein. Melanocytes, responsible for pigment production, are also found here, determining skin color and protecting against UV damage. Langerhans cells, part of the immune system, reside in the epidermis, playing a role in immune responses. The epidermis is constantly regenerating, with new cells pushing up from the basal layer to the surface. Beneath the epidermis lies the dermis, a thicker layer composed of connective tissue, blood vessels, nerves, hair follicles, and sweat glands. This layer provides strength, elasticity, and nourishment to the epidermis. Collagen and elastin fibers, produced by fibroblasts, are abundant in the dermis, giving skin its structural integrity and flexibility. The hypodermis, or subcutaneous tissue, is the innermost layer, primarily composed of fat and loose connective tissue. It acts as an insulator, shock absorber, and energy reserve, connecting the skin to underlying muscles and bones. Understanding these layers is crucial for diagnosing and treating skin conditions effectively. Common skin conditions overview. Skin conditions are incredibly diverse, ranging from minor irritations to chronic diseases requiring lifelong management. Common conditions include acne, eczema, psoriasis, and various infections. Acne, often seen in adolescents, involves inflammation of hair follicles and sebaceous glands, leading to pimples, blackheads, and cysts. Eczema, or atopic dermatitis, is characterized by dry, itchy, and inflamed skin, frequently appearing in patches. Psoriasis is a chronic autoimmune condition, causing rapid skin cell turnover, resulting in thick, silvery scales and red patches. These conditions can significantly impact a person's quality of life, requiring careful diagnosis and tailored treatment plans. Beyond these, fungal infections like ringworm and athlete's foot are prevalent, manifesting as itchy, red, and scaly patches. Bacterial infections, such as impetigo and cellulitis, can cause painful, red, and swollen areas, sometimes with pus-filled lesions. Viral infections, including warts and herpes simplex, present with distinct lesions like bumps or blisters. Allergic reactions, like contact dermatitis and urticaria, also fall under common skin conditions, triggered by specific allergens. Understanding the distinct characteristics of each condition is paramount for accurate diagnosis and effective intervention, ensuring appropriate care for affected individuals. Diagnostic techniques in dermatology. Accurate diagnosis is the cornerstone of effective dermatological treatment, relying on a combination of clinical examination, patient history, and specialized tests. A thorough visual inspection of the skin, hair, and nails is always the first step, noting lesion characteristics, distribution, and patterns. Patient history includes details about symptom onset, progression, previous treatments, allergies, and family history of skin conditions. This comprehensive approach helps narrow down potential diagnoses and guides further investigation. Dermatoscopes, specialized handheld microscopes, are frequently used to examine skin lesions, particularly moles, for early detection of skin cancer. Their magnification allows for detailed visualization of subsurface structures not visible to the naked eye. Further diagnostic tools include skin biopsies, where a small tissue sample is removed for microscopic examination by a pathologist. This is often crucial for confirming diagnoses of inflammatory conditions, infections, and skin cancers. Different biopsy techniques, such as shave, punch, and excisional biopsies, are chosen based on the lesion type and location. Other tests include patch testing for allergic contact dermatitis, fungal scrapings for micrological examination, and bacterial cultures for identifying specific pathogens. Woods lamp examination, using ultraviolet light, can highlight certain fungal infections or pigmentary changes. These diverse techniques ensure precise identification of dermatological conditions. Inflammatory skin diseases. Eczema. Eczema, also known as atopic dermatitis, is a chronic inflammatory skin condition characterized by intensely itchy, dry, and inflamed skin. It often begins in childhood, but can persist into adulthood or develop later in life. The exact cause is complex, involving a combination of genetic predisposition, immune system dysfunction, and environmental triggers. Individuals with eczema often have a compromised skin barrier, making them more susceptible to irritants and allergens. This barrier dysfunction leads to increased water loss and allows allergens to penetrate the skin more easily, triggering immune responses. Common triggers include certain soaps, detergents, fabrics, pollens, and pet dander. The condition typically presents with red, scaly patches, sometimes with oozing or crusting, especially in skin folds. Management of eczema focuses on reducing inflammation, alleviating itching, and restoring the skin barrier function. Topical corticosteroids are a mainstay of treatment, effectively reducing inflammation and itching. Calcineurin inhibitors are another class of topical medications used for long-term management, particularly in sensitive areas. Emollients and moisturizers are crucial for daily use to hydrate the skin and repair the barrier, preventing flare-ups. Avoiding known triggers, taking lukewarm baths, and using gentle, fragrance-free skincare products are also vital. In severe cases, systemic medications or phototherapy may be necessary to control symptoms and improve quality of life. Patient education on skincare routines is paramount. Psoriasis. Types and management. Psoriasis is a chronic autoimmune disease characterized by accelerated skin cell growth, leading to thick, silvery scales and red, inflamed patches. This rapid turnover of skin cells, occurring in days rather than weeks, results in a buildup on the skin's surface. While it can appear anywhere on the body, common sites include the elbows, knees, scalp, and lower back. Psoriasis is not contagious and is believed to have a genetic component, often triggered by environmental factors like stress, infections, or certain medications. There are several types of psoriasis, each with distinct presentations. Plaque psoriasis is the most common form, accounting for about 80 to 90% of cases, presenting as raised, red patches covered with silvery scales. Guttate psoriasis appears as small, drop-like lesions, often after a strep infection. Inverse psoriasis affects skin folds, appearing as smooth, red lesions. Pustular psoriasis features pus-filled blisters, and erythrodermic psoriasis is a severe, widespread redness and scaling. Treatment for psoriasis aims to reduce inflammation, slow down skin cell growth, and remove scales. Topical treatments, such as corticosteroids, vitamin D analogues, and retinoids, are often the first line for mild to moderate cases. Phototherapy, involving controlled exposure to ultraviolet light, UVB or PUVA, is effective for widespread or resistant psoriasis. Systemic medications, including oral retinoids, methotrexate, and cyclosporin, are used for more severe forms. Targeting the immune system. Biologic drugs, a newer class of systemic treatments, specifically target key immune pathways involved in psoriasis, offering significant relief for many patients. Lifestyle modifications, such as stress reduction, avoiding triggers, and maintaining a healthy weight, also play a crucial role in managing the condition. Acne vulgaris, pathogenesis and treatment. Acne vulgaris is a common chronic inflammatory skin condition affecting hair follicles and sebaceous glands, primarily on the face, neck, chest, and back. It is characterized by various lesions including blackheads, open comedones, whiteheads, closed comedones, papules, pustules, nodules, and cysts. The pathogenesis of acne involves 4 key factors: increased sebum production, follicular hyperkeratinization, excessive shedding of skin cells that clog pores, proliferation of the bacterium Cutibacterium acnes, formerly Propionibacterium acnes, and inflammation. Hormonal fluctuations, particularly androgens, stimulate sebaceous glands to produce more sebum, contributing to pore blockage. Genetics, stress, and certain medications can also exacerbate acne. This condition can lead to significant psychological distress and scarring if not properly managed. Treatment for acne aims to address these underlying factors and prevent new lesions and scarring. Topical treatments are often the first line for mild to moderate acne, including retinoids to normalize follicular keratinization, benzoyl peroxide to kill bacteria and reduce inflammation, and topical antibiotics. Oral antibiotics may be prescribed for moderate to severe inflammatory acne to reduce bacterial load and inflammation. For severe nodular cystic acne, isotretinoin, a powerful oral retinoid, is highly effective but requires strict monitoring due to potential side effects. Hormonal therapies, such as oral contraceptives, can be beneficial for women with hormonally driven acne. Adjunctive therapies like chemical peels and laser treatments can also improve skin texture and reduce scarring. A multifaceted approach is often necessary for optimal results. Rosacea, clinical features and care. Rosacea is a chronic inflammatory skin condition primarily affecting the face, characterized by redness, visible blood vessels, papules, and pustules. Unlike acne, rosacea typically occurs in adults, usually starting after age 30. The exact cause is unknown, but it is thought to involve a combination of genetic factors, immune system dysfunction, environmental triggers, and abnormalities in blood vessels. Common triggers include sun exposure, hot beverages, spicy foods, alcohol, stress, and extreme temperatures, which can cause flushing and exacerbate symptoms. There are 4 main subtypes: erythematotelangiectatic rosacea, ETR, with persistent redness and visible blood vessels; papulopustular rosacea, PPR, with redness, bumps, and pimples; phymatous rosacea with skin thickening, often affecting the nose, rhinophyma; and ocular rosacea, affecting the eyes. Recognizing these subtypes is crucial for targeted treatment. Management of rosacea focuses on controlling symptoms, reducing inflammation, and identifying and avoiding triggers. Topical medications, such as metronidazole, azelaic acid, and ivermectin cream, are commonly used to reduce redness and inflammatory lesions. Oral antibiotics, particularly tetracyclines, may be prescribed for more severe papulopustular rosacea due to their anti-inflammatory properties. For persistent redness and visible blood vessels, telangiectasias. Laser and light therapies are highly effective. Sun protection is paramount for all rosacea patients, as UV exposure is a major trigger. Gentle skincare, avoiding harsh products, and maintaining a diary to identify personal triggers are also important components of long-term management. Early intervention can prevent progression and improve patient quality of life. Fungal skin infections. Fungal skin infections, also known as mycoses, are common dermatological conditions caused by various types of fungi, including dermatophytes, yeasts, and molds. These infections thrive in warm, moist environments and can affect different parts of the body, leading to a range of symptoms. Dermatophytes cause conditions like ringworm, tinea corporis, athlete's foot, tinea pedis, and jock itch, tinea cruris, characterized by itchy, red, scaly, and often ring-shaped lesions. Yeast infections, primarily caused by Candida species, can manifest as intertrigo in skin folds or thrush in mucous membranes. Pityriasis versicolor, caused by Malassezia yeast, presents as discolored patches, often on the trunk. These infections are often contagious and can spread through direct contact or shared items. Diagnosis of fungal infections typically involves a clinical examination and confirmation through laboratory tests. A skin scraping or nail clipping can be examined under a microscope with potassium hydroxide (KOH) preparation to visualize fungal elements. Fungal cultures can also be performed to identify the specific species of fungus, guiding targeted treatment. Treatment primarily involves antifungal medications, available in topical, oral, and sometimes intravenous forms. Topical antifungals such as azoles and allylamines are effective for localized infections. Oral antifungals like fluconazole, terbinafine, or itraconazole are reserved for more extensive, severe, or recalcitrant infections. Maintaining good hygiene, keeping skin dry, and wearing breathable clothing are crucial preventive measures. Early and accurate diagnosis is key to preventing spread and recurrence. Bacterial skin infections. Bacterial skin infections occur when bacteria, commonly Staphylococcus aureus or Streptococcus pyogenes, invade the skin through breaks in the barrier, such as cuts, scrapes, or insect bites. These infections can range from superficial to deep, potentially leading to serious systemic complications if left untreated. Impetigo is a highly contagious superficial infection, presenting as red sores that quickly rupture, ooze, and form honey-colored crusts, often seen in children. Folliculitis is an inflammation of hair follicles, appearing as small red bumps or pus-filled pimples around hair shafts. Cellulitis is a deeper infection affecting the dermis and subcutaneous tissue, characterized by rapidly spreading redness, warmth, swelling, and pain. Erysipelas is a superficial form of cellulitis with sharply demarcated, raised borders. Recognizing these distinct presentations is crucial for prompt and effective treatment. Diagnosis of bacterial skin infections is primarily clinical, based on the characteristic appearance of lesions and patient history. In some cases, a bacterial culture from a swab of the lesion or a biopsy may be performed to identify the specific pathogen and determine antibiotic sensitivity. Treatment typically involves antibiotics, chosen based on the suspected bacteria and severity of the infection. Topical antibiotics, such as mupirocin or fusidic acid, are effective for localized, superficial infections like impetigo. Oral antibiotics, including penicillin derivatives, cephalexin, or clindamycin, are prescribed for more extensive or deeper infections like cellulitis. Intravenous antibiotics may be necessary for severe cases or those with systemic symptoms. Good hygiene, wound care, and avoiding skin trauma are important for prevention. Prompt treatment is essential to prevent complications like abscess formation or sepsis. Viral skin infections. Viral skin infections are caused by various viruses that can affect the skin, leading to a wide range of lesions. Common examples include warts, herpes simplex and varicella, chickenpox, or herpes zoster, shingles. Warts, caused by the human papillomavirus, HPV, are benign skin growths that can appear anywhere on the body, often on hands and feet, presenting as rough, flesh-colored bumps. Herpes simplex virus, HSV, causes cold sores, oral herpes. Or genital herpes, characterized by painful, fluid-filled blisters that crust over. Varicella zoster virus, VZV, causes chickenpox in children, presenting as an itchy, generalized rash of vesicles, and shingles in adults, which is a painful, blistering rash, typically confined to a dermatome. Molluscum contagiosum, caused by a pox virus, presents as small, firm, flesh-colored, or pearly papules with a central dimple. These infections are often contagious and can spread through direct contact. Diagnosis of viral skin infections is primarily clinical, based on the characteristic appearance of the lesions. In some cases, laboratory tests such as viral cultures, PCR, polymerase chain reaction, or zinc smear may be used to confirm the diagnosis, especially for atypical presentations or in immunocompromised patients. Treatment for viral skin infections varies depending on the specific virus and severity. Warts can be treated with cryotherapy, salicylic acid, laser therapy, or surgical excision. Herpes simplex infections are managed with antiviral medications like acyclovir, valacyclovir, or famciclovir, which can reduce the duration and severity of outbreaks. Antivirals are also used for shingles to reduce pain and prevent complications. Molluscum contagiosum often resolves spontaneously, but can be treated with cryotherapy or curettage. Prevention often involves avoiding direct contact with infected lesions and vaccination for VZV. Parasitic skin infestations. Parasitic skin infestations are conditions caused by tiny organisms that live on or in the skin, leading to intense itching, rashes, and discomfort. Common examples include scabies, pediculosis, lice, and bedbug bites. Scabies is caused by the Sarcoptes scabiei mite, which burrows into the skin, laying eggs and causing an intensely itchy rash, especially at night. Characteristic lesions include small, red bumps and burrows, often found in fingerwebs, wrists, elbows, and genitals. Pediculosis, or lice infestation, involves tiny insects that feed on human blood, causing itching and irritation on the scalp, head lice, body lice, or pubic area, pubic lice. Bedbugs are nocturnal insects that feed on human blood, leaving itchy red welts, often in a linear or clustered pattern. These infestations are highly contagious and can spread rapidly through close contact. Diagnosis of parasitic infestations often involves a clinical examination and identification of the parasite or its signs. For scabies, a skin scraping can be examined under a microscope to visualize mites, eggs, or fecal matter. Lice infestations are diagnosed by finding live lice or nits, eggs, attached to hair shafts or clothing. Bedbug infestations are identified by characteristic bite patterns, presence of bugs, or fecal stains on bedding. Treatment involves specific anti-parasitic medications. For scabies, topical permethrin cream is the first-line treatment, often applied to the entire body. Oral ivermectin may be used for widespread or resistant cases. Lice are treated with topical pediculicides, e.g. permethrin shampoo, or oral ivermectin. Environmental cleaning, such as washing bedding in hot water and vacuuming, is crucial for all infestations to prevent reinfestation. Patient education on hygiene and contact precautions is vital to prevent spread. Allergic contact dermatitis. Allergic contact dermatitis, ACD, is an inflammatory skin reaction caused by delayed hypersensitivity to an allergen that comes into contact with the skin. Unlike irritant contact dermatitis, which is caused by direct damage to the skin barrier, ACD is an immune-mediated response. Common allergens include nickel, found in jewelry, fragrances, preservatives in cosmetics, rubber chemicals, and plant resins like urushiol from poison ivy or oak. The reaction typically develops 24 to 72 hours after exposure to the allergen, manifesting as intensely itchy, red, swollen, and sometimes blistering skin. The rash usually appears only where the allergen touched the skin, but severe reactions can spread. Repeated exposure to the allergen can lead to chronic dermatitis, characterized by thickening and scaling of the skin. Identifying the specific allergen is crucial for management. Diagnosis of allergic contact dermatitis relies heavily on a detailed patient history and patch testing. Patch testing involves applying small amounts of suspected allergens to the skin, usually on the back, under occlusive patches for 48 hours. The skin is then examined for reactions at 48 and 72 to 96 hours. This helps identify the specific substances causing the allergic reaction. Treatment focuses on avoiding the identified allergen and reducing inflammation. Topical corticosteroids are the primary treatment for acute flares, effectively reducing redness, swelling, and itching. Oral corticosteroids may be prescribed for severe, widespread reactions. Antihistamines can help alleviate itching. Emollients and moisturizers are important for restoring the skin barrier. Patient education on allergen avoidance is paramount to prevent recurrence and ensure long-term management of the condition. Urticaria and angioedema. Urticaria, commonly known as hives, is a skin condition characterized by the sudden appearance of itchy, red, and raised welts, wheals on the skin. These wheals can vary in size, shape, and location, often blanching with pressure and typically resolving within 24 hours in one area, only to reappear elsewhere. Urticaria is caused by the release of histamine and other inflammatory mediators from mast cells in the skin, leading to fluid leakage from blood vessels. Triggers can be diverse, including allergies, foods, medications, insect stings, insections, physical stimuli, cold, heat, pressure, sunlight, stress, or autoimmune conditions. Chronic urticaria persists for more than 6 weeks, often without an identifiable cause. Angioedema is a deeper form of urticaria, involving swelling in the deeper layers of the skin and subcutaneous tissue, often affecting the lips, eyelids, tongue, or genitals. It can be painful and, if it affects the airway, potentially life-threatening. Diagnosis of urticaria and angioedema is primarily clinical, based on the characteristic appearance of the lesions and a thorough patient history to identify potential triggers. For chronic cases, blood tests may be performed to rule out underlying autoimmune conditions or infections. Skin prick tests or specific IgE blood tests may be considered if an allergic trigger is suspected, though allergies are less common in chronic urticaria. Treatment focuses on alleviating symptoms and identifying avoiding triggers. Antihistamines are the cornerstone of treatment, often at higher doses for chronic cases. Non-sedating antihistamines are preferred for daytime use. Oral corticosteroids may be used for severe acute flares, but are generally avoided for long-term use due to side effects. Omalizumab, a biologic drug, is an option for severe chronic urticaria unresponsive to antihistamines. Epinephrine is used for severe angioedema with airway involvement. Patient education on trigger avoidance and medication adherence is vital for managing these conditions. Pigmentary disorders. Vitiligo pigmentary disorders involve abnormalities in the production or distribution of melanin, the pigment responsible for skin, hair, and eye color. These disorders can result in either hypopigmentation, lighter skin, or hyperpigmentation, darker skin. Vitiligo is a chronic autoimmune condition characterized by the loss of melanocytes, resulting in well-defined, depigmented, white patches on the skin. It can affect any part of the body, including the hair and mucous membranes. The exact cause is unknown, but it is believed to involve a combination of genetic predisposition and environmental triggers that lead to the immune system attacking and destroying melanocytes. Vitiligo is not contagious and does not cause physical pain or discomfort, but it can have a significant psychological impact due to its cosmetic appearance. It affects people of all skin types, though it is often more noticeable in individuals with darker skin tones. The patterns of vitiligo can be localized, generalized, or segmental. Diagnosis of vitiligo is primarily clinical, based on the characteristic appearance of the depigmented patches. A Wood's lamp examination, which uses ultraviolet light, can help highlight vitiligo lesions, especially on lighter skin, as they fluoresce brightly. A skin biopsy may be performed in atypical cases to confirm the absence of melanocytes. Treatment aims to restore pigment, repigmentation, or, in extensive cases, to depigment the remaining normally pigmented skin to achieve an even skin tone. Topical corticosteroids and calcineurin inhibitors are often used for localized vitiligo to suppress the immune response and stimulate melanocyte activity. Phototherapy, particularly narrowband UVB, is a common and effective treatment for widespread vitiligo, stimulating melanocytes to produce pigment. Surgical options such as melanocyte transplantation may be considered for stable, localized patches. Camouflage cosmetics can also help improve the cosmetic appearance. Psychological support is an important aspect of patient care. Melasma and post-inflammatory hyperpigmentation. Melasma and post-inflammatory hyperpigmentation, PIH, are common pigmentary disorders characterized by areas of darkened skin. Melasma presents as symmetrical, irregular patches of hyperpigmentation, typically on the face, especially the cheeks, forehead, upper lip, and chin. It is more common in women and often triggered by hormonal changes, example pregnancy, oral contraceptives, sun exposure, and genetic predisposition. The excess melanin is deposited in the epidermis and/or dermis. PIH, on the other hand, is a temporary darkening of the skin that occurs after an inflammatory injury or trauma, such as acne, eczema, burns, or insect bites. It can affect anyone, but is more common and often more severe in individuals with darker skin tones. The inflammation stimulates melanocytes to produce more melanin, which is then deposited in the affected area. Both conditions can be cosmetically distressing and challenging to treat. Treatment for melasma and PIH focuses on reducing melanin production, removing existing pigment, and preventing further darkening. Sun protection is paramount for both conditions, as UV exposure significantly exacerbates hyperpigmentation. Broad-spectrum sunscreens with high SPF and physical blockers, zinc oxide, titanium dioxide, are essential. Topical treatments for melasma often include hydroquinone, a depigmenting agent, often combined with retinoids and corticosteroids in a triple combination cream. Azelaic acid, kojic acid, and vitamin C are other effective topical agents. For PIH, the underlying inflammatory condition must be treated first, followed by similar topical agents to fade the dark spots. Chemical peels, microdermabrasion, and laser therapies can be considered for resistant cases, but must be used cautiously, especially in darker skin types, to avoid worsening PIH. Consistent and long-term treatment is often required for satisfactory results. Benign skin growths. Benign skin growths are common, non-cancerous lesions that can appear on any part of the body. While generally harmless, they can sometimes cause cosmetic concern, irritation, or mimic more serious conditions, necessitating proper diagnosis. Common types include seborrheic keratoses, skin tags, acrocordons, cherry angiomas, dermatofibromas, and moles. Nevi. Seborrheic keratoses are waxy, stuck-on-looking lesions, often brown or black, that can appear anywhere but are common on the trunk, face, and scalp. Skin tags are small, soft, flesh-colored or brownish growths that often hang off the skin, typically found in skin folds. Cherry angiomas are small, bright red bumps composed of dilated blood vessels. Dermatofibromas are firm, reddish-brown bumps that often dimple when squeezed. Moles are common pigmented lesions that can vary in size, shape, and color. Most moles are benign, but changes in their appearance warrant medical evaluation. Diagnosis of benign skin growths is usually clinical, based on their characteristic appearance. A dermatoscope can be used to examine pigmented lesions more closely to differentiate them from melanoma. In cases of diagnostic uncertainty or if a lesion is symptomatic, a skin biopsy may be performed to confirm its benign nature. Treatment for benign growths is generally not medically necessary unless they are symptomatic, examples, irritated by clothing, or for cosmetic reasons. Removal options include cryotherapy, freezing, shave excision, surgical excision, electrocautery, or laser therapy, depending on the type, size, and location of the growth. For example, skin tags are often snipped off, while seborrheic keratoses can be frozen or scraped. It is important to reassure patients about the benign nature of these growths while offering appropriate removal options if desired or indicated. Precancerous lesions, actinic keratosis. Precancerous lesions are abnormal skin growths that have the potential to develop into skin cancer if left untreated. Actinic keratosis, AK, is the most common type of precancerous skin lesion resulting from chronic sun exposure. AKs are typically rough, scaly patches or bumps that range in color from skin-toned to reddish-brown, often feeling like sandpaper when touched. They commonly appear on sun-exposed areas such as the face, scalp, ears, lips, and back of the hands and forearms. While most AKs remain benign, a small percentage can progress to squamous cell carcinoma, SCC, a type of non-melanoma skin cancer. The risk of progression increases with the number of AKs present. Early detection and treatment of AKs are crucial for preventing the development of invasive skin cancer. Individuals with a history of significant sun exposure, fair skin, and older age are at higher risk. Diagnosis of actinic keratosis is primarily clinical, based on the characteristic rough texture and appearance of the lesions in sun-exposed areas. A dermatoscope can aid in visualizing specific features. If there is any suspicion of progression to squamous cell carcinoma, a skin biopsy may be performed to confirm the diagnosis and assess the extent of cellular atypia. Treatment options for AKs aim to destroy the abnormal cells and prevent progression to cancer. Field treatments which treat a larger area of skin include topical chemotherapy agents, example 5-fluorouracil, topical immunomodulators, example imiquimod, and photodynamic therapy PDT. Lesion-specific treatments include cryotherapy, freezing, curettage and electrodesiccation, or surgical excision for isolated thicker lesions. Regular follow-up and diligent sun protection are essential after treatment to monitor for new lesions and prevent recurrence. Patient education on sun safety is a critical component of care. Skin cancers, basal cell carcinoma. Skin cancer is the most common type of cancer, with basal cell carcinoma, BCC, being the most prevalent form, accounting for about 80% of all non-melanoma skin cancers. BCC arises from the basal cells in the epidermis and is primarily caused by chronic exposure to ultraviolet UV radiation from the sun or tanning beds. It typically grows slowly and rarely metastasizes, spreads to other parts of the body, but it can be locally destructive if left untreated, invading surrounding tissues, bone, and cartilage. ACC commonly appears on sun-exposed areas such as the face, neck, ears, scalp, and hands. There are several clinical subtypes, including nodular BCC, pearly papule with rolled borders and telangiectasias, superficial BCC, red, scaly patch resembling eczema, and infiltrative or morphiform BCC, scar-like, ill-defined lesion. Early detection is crucial for successful treatment and minimizing tissue damage. Diagnosis of basal cell carcinoma is typically made through a skin biopsy, where a small piece of the suspicious lesion is removed and examined under a microscope. Clinical examination with a dermatoscope can help identify characteristic features. Treatment options for BCC depend on the size, location, and subtype of the tumor, as well as the patient's overall health. Surgical excision, including Mohs micrographic surgery, is the most common and effective treatment, offering high cure rates. Mohs surgery is particularly useful for BCCs on the face or other cosmetically sensitive areas, as it removes cancerous tissue layer by layer while preserving healthy skin. Other treatment modalities include curettage and electrodesiccation, cryotherapy, topical chemotherapy, example 5-fluorouracil, topical immunomodulators, example imiquimod, and radiation therapy. Regular skin self-exams and annual dermatological checkups are important for early detection and prevention of recurrence. Sun protection measures are vital for reducing the risk of developing new BCCs. Squamous cell carcinoma. Squamous cell carcinoma, SCC, is the second most common type of skin cancer, arising from the keratinocytes in the epidermis. Like basal cell carcinoma, it is primarily caused by chronic exposure to ultraviolet UV radiation, particularly cumulative lifetime exposure. SCC can also develop from precancerous lesions like actinic keratoses or in areas of chronic inflammation, scars, or non-healing wounds. It typically presents as a firm, red nodule, a scaly patch, or a sore that doesn't heal, often with a crusted or bleeding surface. Common locations include sun-exposed areas such as the face, ears, lips, scalp, and hands. While most SCCs are localized, they have a higher potential than BCCs to metastasize, especially larger, deeper, or recurrent lesions, or those on certain high-risk sites like the lips or ears. Early detection and prompt treatment are crucial to prevent spread and improve prognosis. Diagnosis of squamous cell carcinoma is confirmed by a skin biopsy, where a tissue sample is taken for microscopic examination. Clinical examination with a dermatoscope can help identify suspicious features. Treatment options for SCC are similar to those for BCC, but may be more aggressive due to the higher risk of metastasis. Surgical excision is the most common and effective treatment, aiming for complete removal of the tumor with clear margins. Mohs micrographic surgery is often preferred for SCCs on the face, ears, lips, or other high-risk areas, as it offers precise margin control and tissue preservation. Other treatment modalities include curettage and electrodesiccation for superficial lesions, radiation therapy, and, in advanced cases, systemic chemotherapy or targeted therapy. Regular skin self-exams, annual dermatological checkups, and diligent sun protection are essential for prevention and early detection. Patient education on recognizing suspicious lesions and practicing sun safety is paramount. Melanoma, early detection and prognosis. Melanoma is the most dangerous form of skin cancer arising from melanocytes, the pigment-producing cells in the skin. While less common than BCC or SCC, melanoma has a higher potential for metastasis and can be life-threatening if not detected and treated early. It can develop from an existing mole or appear as a new dark spot on the skin. Risk factors include excessive UV exposure, especially blistering sunburns in childhood, a high number of moles, atypical moles, a family history of melanoma, and fair skin. The ABCDE rule is a helpful guide for early detection: asymmetry, border irregularity, color variation, diameter greater than 6 mm, and evolving, changing, size, shape, or color. Any suspicious lesion should be promptly evaluated by a dermatologist. Early detection significantly improves prognosis. Diagnosis of melanoma is confirmed by an excisional biopsy, where the entire suspicious lesion is surgically removed and sent for histopathological examination. If melanoma is confirmed, further staging may involve sentinel lymph node biopsy to check for spread to regional lymph nodes and imaging studies for distant metastasis. Treatment for melanoma primarily involves surgical excision with wide margins, the extent of which depends on the tumor's thickness, Breslow depth. For advanced or metastatic melanoma, systemic therapies such as immunotherapy, e.g. PD-1 inhibitors, targeted therapy, for specific genetic mutations like BRF, chemotherapy, or radiation therapy may be used. Regular self-skin exams, professional dermatological skin checks, and strict sun protection are paramount for prevention and early detection. Patient education on the ABCDEs of melanoma and sun safety is a critical public health message. Topical therapies in dermatology. Topical therapies are a cornerstone of dermatological treatment, involving the application of medications directly to the skin. This approach allows for targeted delivery of active ingredients to the affected area, minimizing systemic side effects. Various formulations exist, including creams, ointments, gels, lotions, foams, and solutions, each suited for different skin types and lesion locations. Creams are oil in water emulsions, generally well absorbed and suitable for most skin types. Ointments are oil-based, providing excellent hydration and occlusion, ideal for dry, thick, or scaly lesions. Gels are alcohol-based, non-greasy, and good for hairy areas or oily skin. Lotions are lighter, water-based, and cover large areas easily. The choice of vehicle significantly impacts drug penetration and patient adherence. Proper application technique, including frequency and amount, is crucial for efficacy. Common active ingredients in topical therapies include corticosteroids, retinoids, antibiotics, antifungals, and immunomodulators. Topical corticosteroids are potent anti-inflammatory agents used for conditions like eczema, psoriasis, and contact dermatitis, available in varying strengths. Topical retinoids, e.g. tretinoin, adapalene, are used for acne, psoriasis, and photoaging, normalizing cell turnover. Topical antibiotics, e.g. clindamycin, erythromycin, target bacterial infections and acne. Antifungals, e.g. azoles, allylamines, treat fungal infections. Topical calcineurin inhibitors, e.g. tacrolimus, pimecrolimus, are immunomodulators used for eczema, offering a steroid-sparing option. Understanding the properties of different topical agents and their appropriate use is essential for effective and safe dermatological care. Patient education on application and potential side effects is also vital. Systemic medications for skin diseases. Systemic medications are drugs taken orally, by injection, or intravenously, affecting the entire body to treat widespread or severe skin conditions that do not respond to topical therapies. These medications work by modulating the immune system, reducing inflammation, or targeting specific cellular pathways. They are typically reserved for more serious conditions like severe psoriasis, extensive eczema, severe acne, or autoimmune blistering diseases. While highly effective, systemic treatments often carry a higher risk of side effects compared to topical agents, necessitating careful patient selection, monitoring, and risk-benefit assessment. Patient education regarding potential adverse effects and the importance of adherence is critical for safe and effective use. Regular laboratory monitoring is frequently required to ensure patient safety. Common classes of systemic medications include oral corticosteroids, conventional immunosuppressants, antibiotics, antifungals, retinoids, and biologics. Oral corticosteroids, example, prednisone, are potent anti-inflammatory agents used for acute, severe flares of various inflammatory conditions, but their long-term use is limited by significant side effects. Conventional immunosuppressants, example, methotrexate, cyclosporin, are used for chronic, severe inflammatory and autoimmune skin diseases. Oral antibiotics, example tetracyclines, doxycycline, treat bacterial infections and have anti-inflammatory effects in conditions like acne and rosacea. Oral antifungals, example fluconazole, terbinafine, treat widespread or recalcitrant fungal infections. Oral retinoids, example isotretinoin, acitretin, are highly effective for severe acne and psoriasis, respectively. Biologic drugs are a newer class of targeted therapies that specifically block inflammatory pathways, offering significant efficacy for severe psoriasis, chronic urticaria, and atopic dermatitis with fewer systemic side effects than older immunosuppressants. Each class has specific indications, contraindications, and monitoring requirements that must be thoroughly understood. Phototherapy and laser treatments. Phototherapy and laser treatments utilize specific wavelengths of light to treat various skin conditions, offering targeted and effective therapeutic options. Phototherapy involves exposing the skin to controlled doses of ultraviolet UV light, primarily narrowband UVB, NB-UVB, or psoralen plus UVA, PUVA. NB-UVB is commonly used for widespread psoriasis, eczema, and vitiligo, as it suppresses inflammation and stimulates melanocytes. PUVA combines an oral or topical photosensitizing drug, psoralen, with UVA light, used for more severe or resistant cases. These treatments require specialized equipment and are administered in a clinical setting under strict medical supervision. The mechanism involves modulating immune responses in the skin and influencing cell growth. While effective, potential side effects include sunburn, dryness, and an increased risk of skin cancer with long-term use, necessitating careful monitoring. Laser treatments use highly focused beams of light to target specific skin components or conditions. Different types of lasers are employed based on their wavelength and target chromophore, for example, melanin, hemoglobin, water. Pulsed dye lasers, PDL, target blood vessels and are effective for conditions like rosacea, port wine stains, and cherry angiomas. Fractional lasers create microscopic columns of injury in the skin, stimulating collagen production and improving texture. Used for acne scars, wrinkles, and melasma. Pigment-specific lasers, example, Q-switched lasers, target melanin, effectively removing tattoos and treating pigmentary disorders. Hair removal lasers target melanin in hair follicles. These procedures are performed by trained professionals and can offer significant cosmetic and therapeutic benefits. Understanding the principles of light-tissue interaction is crucial for safe and effective laser application. Patient selection and post-treatment care are paramount for optimal outcomes. Dermatological procedures, biopsies. Dermatological procedures encompass a range of interventions performed in a clinic or outpatient setting for diagnostic or therapeutic purposes. Skin biopsies are among the most fundamental diagnostic procedures, involving the removal of a small piece of skin tissue for microscopic examination. This is crucial for confirming diagnoses of skin cancers, inflammatory conditions, and infections when clinical appearance alone is insufficient. There are several types of biopsies, each selected based on the lesion's characteristics and location. A shave biopsy removes only the superficial layers of the skin, ideal for raised lesions like seborrheic keratoses or superficial BCCs. A punch biopsy uses a circular blade to remove a full-thickness core of skin, useful for inflammatory conditions or suspicious pigmented lesions. An excisional biopsy removes the entire lesion with a margin of healthy skin, often used for suspected melanoma or larger lesions. Proper technique and sterile conditions are paramount to ensure accurate diagnosis and minimize complications. Before any biopsy, the area is typically cleaned and numbed with a local anesthetic. The choice of biopsy technique depends on the suspected diagnosis, the size and depth of the lesion, and its location. After the tissue is removed, the wound is usually closed with sutures or allowed to heal by secondary intention, depending on the biopsy type and site. The tissue sample is then sent to a pathology laboratory for microscopic analysis, where a dermatopathologist examines the cells and tissue architecture to render a diagnosis. Potential complications of biopsies include bleeding, infection, scarring, and nerve damage, though these are generally rare. Patient education on wound care, potential scarring, and follow-up instructions is essential for optimal healing and management. Understanding the indications and limitations of each biopsy type is critical for accurate dermatological practice. Patient education and lifestyle management are integral components of effective dermatological care, empowering individuals to actively participate in their treatment and prevention of skin diseases. Providing clear, understandable information about their condition, treatment plan, potential side effects, and expected outcomes is crucial. This includes explaining the importance of medication adherence, proper application techniques for topical therapies, and the rationale behind systemic treatments. Educating patients about triggers for their specific conditions, such as sun exposure for rosacea or certain foods for eczema, helps them make informed lifestyle choices. Encouraging open communication and addressing patient concerns fosters trust and improves compliance. Tailored advice, considering cultural background and individual circumstances, enhances the effectiveness of educational efforts. Lifestyle modifications play a significant role in managing and preventing many skin conditions. Sun protection is paramount for preventing skin cancers, photoaging, and exacerbation of conditions like melasma and rosacea, involving consistent use of sunscreen, protective clothing, and seeking shade. Stress management techniques can help reduce flares of psoriasis, eczema, and acne. A balanced diet, adequate hydration, and regular exercise contribute to overall skin health. Avoiding known irritants and allergens, maintaining good hygiene, and using gentle skincare products are essential for sensitive skin conditions. For chronic conditions, ongoing support and resources, such as support groups or educational materials, can greatly improve the patient's quality of life. Emphasizing a holistic approach to skin health, integrating medical treatments with healthy lifestyle choices leads to better long-term outcomes.